So I am a dermatologist, the ones of you that already know me. I also do general practice. I have a resident or two and intern and all that fun stuff. We were VetCAT #1. So with that, we'll kind of go through some things. I was requested to do some ear anatomy. So we'll do some of that at the beginning, and then we'll roll into some cases that I think highlight what would have been derm that may not have actually been derm, but we still took care of them. I think it's put me in a place where I've had to increase my skill level on a few things. Dr. Thomas on this photo, I don't know if you can see, but that's a styrofoam ice chest lid, because a lot of times if you place these patients in sternal recumbency, for when I'm dealing with ears, not as much with teeth, but ears and noses, I want them to be in sternal recumbency with that head relatively flat. I can do some corrections with the software for the VetCAT, quite a bit actually, but I want to be able to use my brain and say, okay, if there's fluid or mucus or otoliths or anything like that, I want gravity to make that settle so that I can tell, is it something that's gravity dependent? If I rotate them and put them in lateral recumbency and scan them that way, it works fine for dentition. And that's usually what I'll do for teeth if that's the only thing I'm worried about. But if I'm concerned about ears or sometimes with nasal cavities, I will set them more up in this position. And then if I'm really stressed about what I've got and I can't convince myself, I will flip them 180 degrees. So if I did them sternal, I may do them in dorsal and see if that stuff moves, because oftentimes I'm not using contrast. But the styrofoam doesn't show up and it doesn't seem to cause me any grief, and it gives them a firm yet flat surface that I can set their mandible on, and they usually lay pretty flat versus otherwise, right, they'll lean over. If you're trying to lay them, they end up with their head tilted a bit. So it just helps me get level. This is usually us, right? We're all arguing about what about this or what about that, and usually we all end up seeing the same stuff. If we go through, you know, external ear canal, middle ears, a lot of anatomy is some of the newer VetCAT users are learning about. But for me, hopefully you'll at least see my mouse arrow here, but just inside the eardrum is a tympanic cavity. The tympanic bulla would be our space down below. It's probably worth noting the little ledge that comes over in here. When people talk about a total ear canal ablation, Bulla osteotomy, and getting inadequate clearance of that cavity, that's oftentimes, in my experience, that shelf inhibits a lot of people from getting in there and cleaning out that membrane that lines that cavity. The other thing, after dealing with some of the human ENTs, you know, we were all trained stay out of the attic or stay away from the roof because bad things happen when we go up there. But I still think there may be some issues that get left behind when we avoid it completely. Just some things that we can normally see on otoscopic exam. If we look, we can see the malleus through the tympanum here. This is a reasonably nice looking tympanum. If you see that grayish white line running right through there, remind me about that in a bit, but that's actually a structure in the middle ear that we're able to see. And this line that we're seeing across here is actually the separation between the pars flaccida and the pars tensa. But even on cone beam CT, not so much my experience with the more traditional CT units on the human side, but we can see the malleus. When I first started sending these in for the radiologist to interpret, I started asking them, why don't you comment on the ossicles? And they said, we can't see the ossicular chain in CT. I said, you need to look again because they're there on every study I've sent you. And we ended up getting a different radiologist ultimately. We can even see the pars tensa and the pars flaccida under certain circumstances. This is a pretty normal dog. but can you see the little bubbly looking structure right here that I'm outlining, the arrow's pointing to? But that little bubble that I'm outlining, the black space above that white line there, is actually the pars flaccidus, the loose part of the tympanic membrane. I've got some other stuff coming here. We'll look at this. When we looked at the CT image of the normal dog skull, you can't always see the angle at which the pars tensa enters the canal. So with this image here, I have filled the tympanic bulla and tympanic cavity with contrast media, and this is where it's just leaking out. But this is the whole cavity. So right up near the round window and stuff like that, it's full of contrast. The whole tympanic bulla is full of contrast. But see the little void that's back in here? I think that even though we do a lateral or a ventral bull osteotomy, looking in some of these crevices is where some of that soft tissue, I think, becomes left in place. This image over here is just essentially this same CT that's been a 3D rendition where it's been rotated. So this area with a little bit of red here is actually the angle of the TM, or tympanic membrane, and this is the bulla. I'm gonna also kind of highlight the auditory tube, or the eustachian tube, as most of us know. So I cannulated the auditory tube with a 3.5 French red rubber, and then I filled that red rubber with contrast media, because this was probably 40, 50 pound patient, deceased patient, okay? But this contrast, because remember, we get nasopharyngeal polyps in cats, and we get polyps sometimes in dogs. But knowing that pathway, if we look on the left here, this is the CT built us this picture on the right by me tagging and marking the path that I wanted it to follow. So it's going from the tympanic membrane through the bulla, through the osseous auditory tube, out into the nasopharynx. Just some basic structures that we can visualize on CT that are not always as easy to visualize grossly. The cochlea, but we can see the promontory ridge here, which is represented here. It's a canine ear that the eardrum's been removed. So you can see this cochlear prominence otoscopically through the eardrum. It'll be visible as a shade of gray. We can also see the round window otoscopically. But before, on that image where I said, remind me later, this is a structure you were seeing through the eardrum, and that's the tympanic bulla ridge. When I was training, they called it Rosie Chuck's ridge, and that's who I always think of when I do this. But this is that bulla septum, or the tympanic bulla ridge. You can see it on CT, which most times radiologists won't give you any grief, but occasionally you'll see this little glob sitting here, and they'll want to call that an otolith, which for me, that means I get worried about something floating loose in the middle ear that might be causing the patient a problem. But in reality, that's not the case. The bulla septum, or the bulla ridge, can have these little bony spicules, and that's what you're seeing, is you've gotten just enough in cross section that it looks like it's floating in space. And that's what's important when we're looking at some of these studies. You know, a lot of the ones that I'll show you tonight, most of them are at about a 0.3 millimeter slice thickness, maybe 0.4, but I have a couple where I've merged maybe 10 millimeters, because I want it to be a fusion of multiple images to where I can see some depth. The other thing that I find interesting that most of us in our profession don't recognize, dermatologist, general practitioner, surgeon, anybody else, but the actual location, dorsal to ventral, where the auditory tube actually connects the middle ear space to the nasopharynx, and it's actually quite dorsal. If you look, here's the floor of the tympanic bulla. right? And then this is that same image, different cross section. This is that red rubber catheter that's full of contrast. So it's quite dorsal. So I had a dermatologist call me, and them and their resident were doing a flush. And what they had done is, you know how sometimes when we're doing a procedure, the head might be a little bit down in the wet table, so it's pointing downhill. So the dog just started having prolific volumes of fluid coming out of the nose, and then when they raise the head up a little bit, it stops. And then they lower it down and start coming again. And I just told them, I said, you know, ultimately, you're just at that point. If you tilt the head up, it's going to run back out their myringotomy site, or it's running down the back of the dog's throat. So I said, you're better off just let it hang down, right? But all of these structures, you can see most all of this stuff. You can't see the auditory tube or the eustachian tube opening without having an angled scope to look around the corner. But at least otoscopically with good equipment, you can actually see almost all of those structures. They're just through cellophane at that point. I wanted to highlight some young cats, because most of us with VetCAT, without VetCAT, with CT, without CT, with X-ray, without X-ray, most of us that get a young cat that has a oral polyp or nasopharyngeal polyp, most times we don't do any advanced imaging on those cases, right? We've seen them our whole careers, and we reach in there, we put traction on, we remove the polyp. Various people will put those patients on steroids for a period of time and then reassess. So this is a young cat. This is all the same patient, just serial images. I thought the cochleas were really pretty here, right? They're nice and symmetrical. You can fine tune the images nicely with a VetCAT. I used to hate that in school because you could never, you know, if you didn't set them up perfect, you got what you got, and there's very little correction. But I want to point out, if you look at the bulla wall thickness, can you appreciate that both bulla are filled with either fluid, pus, soft tissue? They're not aerated bullae. But look at the thickness of the bulla from left to right. And then if you look in here, a little bit different, more forward, where we're picking up the dorsolateral and the ventromedial compartments a little more separately. But notice they're aerated above and below a volume of what is likely soft tissue. This cat truly had bilateral oral polyps, where our concern was, as a cat less than a year of age, will this bulla osteitis cause us any long-term grief? For this particular cat, it did not, but I'm going to show you some others that may change that thought. This is a patient that presented for concern of middle ear disease or polyp. The veterinarian had done a really good job getting in there to clean to the best of their ability with their regular otoscopes. But this was the best picture that they could get as far as status of the eardrum. It was referred to be cleaned, and they had requested that we do myringotomies for them to evaluate the middle ear for fluid, pus, etc. We did end up doing CT after we cleaned these ears. Interestingly, there was some myringitis. The tympanic membrane can get inflamed, and when it does, oftentimes after it's had all this volume of debris caked against it, it will become more opaque or more white to where we can't really see through it, which makes it much more difficult, even with the best equipment, to determine if something's going in the middle ear or not. This particular cat, these are really nice. This is the same patient. Really nice, well aerated, you know, pretty symmetrical bone thickness in the bullae. You can see the acicular chain here on both sides. The malleus, we're just not quite in the right section to pick it up, but part of the malleus, incus, and stapes are there. Same cat, right? I'm going through this multiple. If you think about gravity, if I'm looking for small volumes of fluid or tissue, small volume of fluid will almost always be gravity dependent. So I'll look at what I think would be the furthest or most dependent portion of that bulla. And you can just go through those individual slices in whatever way. This is how I do it most, is I will go in this view to where I feel like I'm near the deepest, and then most ventral here. If I get a canal that I can clean this in a cat, the dorsolateral compartment, it's not so easy for us to lavage the ventromedial compartment, right? There is a communication there, but it can be quite narrow, and we're not going to be able to cannulate that. That's where the surgeons or those of us that do ventral bulla osteotomies, I think there's a decent number of cats that get set up for failure because we don't refer them and potentially have surgery done. I'll show you one that had surgery, but I haven't seen post-ops on it. Does anybody nod of head see anything wrong with this cat? Yeah, I'll kind of, this doesn't normally live above the soft palate, right? This one presented for a nasal workup, for chronic nasal discharge, stertorous breathing. You know, most of us in practice, we would have said, oh, that cat may have a polyp, younger cat. But that thing, it's got some size to it. But the middle ear cavity was also full of fluid. That cat did pretty well after just removal of the polyp. I'm going to change gears just a little bit. So if we look at this view here, we can see the TMJ. That's something I love about the images that we can do, because it allows us, compared to dental intraoral x-rays or our traditional x-rays, I can get this in any position I want. This cat actually presented for being seemingly painful when it was eating. So if you look, this TMJ looks pretty normal, although none of us, unless we looked at CT, have ever seen kind of that view. But something just, as the dermatologist would say, having to look at this, something ain't right here. And then if we look over on this view of the same patient, that TMJ ain't any kind of normal. That needs somebody that likes to do surgery and maybe take a little chunk of bone out of there so that cat can, and once that cat was asleep, I don't know how they really thought that cat was opening its mouth, because essentially all it could do, almost no movement. So this cat's mouth was actually almost fixed. So I don't know how we ever did an oral exam. You should have seen me trying to intubate it. Oh, wait, do you see an endotracheal tube in this study? I'm like, I can't open the cat's mouth enough. I would have had to use a scope to intubate it. I'm like, I'll sedate it because it's less than a minute, right? So I can have a study done. So this is my attempt at a 3D image of that cat to give you an idea of how messed up that was. I would suspect that this was a traumatic injury at some point, because I can almost envision old fracture here and that kind of stuff. But think about when you're sending the surgeons in for doing a TICA and facial nerve and all that stuff in here. It's a lot of fun anatomy. So you remember I said some of these young cats, we don't know what their bullas actually look like, because we never really looked. We always said, yeah, we'll just pull the polyp out and they'll do great. If you had this study, would you be as inclined to tell that owner of that cat that's less than a year of age, your cat's going to be great, we're going to pull this polyp out of its ear and you're going to be perfect? It was barely emerging out of the tympanic membrane into the horizontal canal. So there's areas where that's 6 millimeters thick bone and there's holes in it. Look how, if we look in there, this is the cat that Dr. Oakes down in Largo just removed. I had him, it's a veterinary technician's patient or pet, and I asked him if they could do a ventral bulla osteotomy on this for me and get most of that nastiness out of there. And they apparently did it this past week, and so far recovery's been great. And you know, they've been treating topically an Otitis Externa. By the time I saw it, it was a multi-drug resistant Otitis Externa, but it doesn't mean what was in this bone was that multi-drug resistant organism, right? So I just told the surgeon, hey man, when you go get this, I need you to culture some of that bone or some of the tissue or something. Super sensitive bug. He said it was sensitive to near everything on the culture and sensitivity, and the cat's doing great. But my concern is, if I had told him it's just a polyp and I didn't scan it and I didn't look, that the only reason that I think we miss some things is we just don't look. This particular patient also had some stertorous breathing. I thought, well, maybe I just missed a polyp when I looked up with a scope. But as we went through the CT, there was enough soft tissue swelling around this bulla that it was occluding part of the nasopharynx. So it's pretty cool, unless you're that cat. But if you look, this is that cat's 3D imagery. So there's your opening to the auditory canal, right? Or not the auditory canal, the external acoustic meatus. Can you see what I'm highlighting right there? That's the malleus. So it even picked up the malleus. David, I'll say I'm impressed because this is my first time playing with some of the updated software revision. And we can actually see the malleus in this rebuild. And I didn't do it looking for it, but it showed up nonetheless. But I look at all the defects and size differences in that bulla. I don't dislike doing a ventral bulla osteotomy. I called the surgeon and said, I want you to look at the images before I volunteer you for this, because I don't know that you will be appreciative. And he was cool with it. We'll see. I told him he'll probably have to do the second one. I'm going to let y'all look at this image for a little bit while I drink some tea. So this one actually came to us for a chronic non-healing draining tract. When they did their intraoral films for teeth, they had identified there was a missing tooth, some other various things. He sent me pictures after he pulled these sequestrum out of that dog's jaw. So he just went in there. He said they were just loosely sitting in there. All he did was all but have to cut in there, grab them, and take them out and close it up. He's like, why didn't you do it? It's one of the few times I did that. I'm a dermatologist. But anyway, the dog's doing great after that. So this is another one of mine that was referred for chronic non-healing wound. They have this is a defect that you could see surprisingly on the CT, but also to the point where you can see the teeth through the hole. And then if you look at that dog's dentition, there aren't many teeth that need to stay in that dog's head. But it was ironic to me that dental disease had been ruled out as the cause for that tract, which I'm not real sure how, but it was in the records that it was not from dental disease. So y'all can use your own judgment there. We get a lot of patients that are referred with chronic otitis externa, and the concern there, because it's always been in the literature, chronic otitis externa that is seemingly incompletely responsive may have a middle ear component that allows that secondary infection in the external ear canal to reoccur. Historically, how do we evaluate the middle ear if we didn't have advanced imaging? Well, we would clean the ear canal, we'd try to dry it out, we'd use otoscopes and try to evaluate that tympanum, and if we thought it was bulging or opaque or diseased, we would oftentimes do a myringotomy, and we mostly felt that we're not going to do any harm, because right above all, we're supposed to do no harm. I will tell you, having done this for a little while now, there's enough patients that have had myringotomies done, sometimes necessarily done, but oftentimes as a venture of a diagnostic test, where there are complications. I've had cats and dogs with non-healing defects in their tympani for years that they died with a hole in their tympanum, and now several times a year we have to flush out their middle ear because eventually the cerumen or wax or foreign body that would have come out of their external canal migrates into their damn middle ear. So it's, I guess I want to impose upon all of us as a profession that myringotomy is not necessarily benign in its pathway of things. Anyway, so this was a patient that did have chronic otitis externa, and when Dr. Arachi went to evaluate whether or not a myringotomy was warranted, she just did a CT. She found no fluid. She did find some chronic changes in the canals, but she saved that patient from having to do myringotomies. You can see, soft tissue here, certainly thicker in these canals than what we normally like. You can see a little bit of calcification there as well. But the middle ear cavities look great. So we don't have to poke holes in that. This little bit different patient, more mature patient, presented for possible polyp or middle ear disease. Had a history of chronic rhinitis. When I say chronic, couple months duration. And ultimately, we did scan this dog because as you talk to the owner, she says, yeah, occasionally it'll do some sneezing and you'll see a little blood splatter. But just some of the intra-op rhinoscopy images. That's the other thing too, is I can use that study to help me map out exactly how far and exactly where I'm going to go. So I can measure it. I can put tack marks in and say, I want to go 2.5 centimeters up the right side, and I want to biopsy toward the floor. I can navigate that and map it out. We can do that with other things as well, but it works out really nice. Maybe before too long, we'll have some navigation going too, huh, David? Yeah, but there's some of the rhinoscopy images, and it's nice because the pathologist that reads a lot of our stuff, she's like, you give me such nice nasal biopsies. She says, everybody else is using these needles and it's all blind. And I'm like, yeah, no, I don't like that. So in the general practice setting or the referral setting, this was referred to me by the dentist. The dentist saw it because the dog was having difficulty with food prehension following a dog attack. If you notice, that dog's got significant facial swelling, soft tissue swelling. He's like, Mike, I can't tell what the hell has happened to the dog. His mouth doesn't move normally, and I'm not sure. So I tell him, well, send it over. So we'll see all the things you can. It wasn't shot either. This is the housemate bit it in the skull. So there's a tooth puncture into the cranial vault, fractured mandible, cranial vault puncture. I don't have it in the picture, but out here it's broken. Zygomatic arch is broken. Here's another fragment here. Believe it or not, other than facial nerve paralysis on that side, that dog's still happy eating. They had to do a feeding tube for a period of time till the jaw could get worked on. But, they called me. They said, we don't have anything that we can assess what's really happened to this dog, right? Because the intraoral film's not going to tell them about all the other stuff. Yeah, I asked them if they wanted to do anesthesia on it now. And they're like, no, not really. But I did it. The dog was pretty laid out. I gave it midazolam, butorphanol. I scanned it in less than a minute and sent him images. So this is a videodoscopic photo. This ear canal is under saline, so it's all fluid-filled canal to help with magnification. This is, if it's not a 4K image, it's at least an HD image. It's a 4K camera at least, but if we were to all look at that, I don't feel like it's completely translucent. I don't feel like I can see completely through it. So I look at that and go, is this a patient that I do a myringotomy on or is it not? So if I do CT, this is, I'm not going to do myringotomy on that patient. But we were tossing the coin. One of us was voting, yes, do it. The other was voting, no, don't. So, we've worked in, most of our ear workups include CT. Most of our nasal things include CT. And to be completely honest, in the general practice, partly out of time and partly because I've gotten to the point where I'm a little bit more spoiled and dependent on it. Most of my dentals I spend with a CT. So if you look at this separate eardrum, different patient, you know, it's normal for them along the floor to have a little bit of hair near the tympanum. I can maybe convince myself I can see the edge of the malleus going through there, but other than that, it looks pretty damn opaque to me. I'm not convinced. But again, here's another patient. The bulla thickness is pretty symmetrical. They're both well aerated. You know, that saved that dog myringotomy, right? So I think we're sort of on time, unless somebody tells me otherwise. They wanted me to be available for some questions. So hopefully y'all will have some, and hopefully these were some cool cases for no matter what kind of practice you do. So I'm going to open up for questions.
I have one. Can you hear me okay?
Yep.
So if you're using CT to help you with your dentistry, are you setting them up for dentistry and then being able to get that whole scan within 1 minute?
So usually what I do, because you know my practice, so I have some things spread out a little bit. My dental suite's not quite big enough. So what I do is I induce them, I walk them in, I CT them. That takes about a minute. While they're hooking it up and starting to scale the teeth, I'm looking at all the images. And I make a list of everything that I plan to extract. So usually before they've even scaled half an arcade, I'm already back with a list of all the extra work we have to do. Because that's one thing I'll tell you, it as much as I feel like I learned by learning how to do dental x-rays, this is a whole nother level. So it makes me, the only thing I use my regular dental sensor for right now is if I only had to do like one extraction or two extractions, instead of spinning the whole head again, I'll do my post extractions with the little dental sensor.
But it saves a lot of time.
It does. All right, guys. Have a great night. Stay safe.
Good night.
Stay working. Thanks for attending all.
Good night.